Bismillahirrahmanirrahim. Our topics is motor development and limping. We will study normal gross motor milestones. Gross motor skills. The first motor skills to be developed are the gross motor skills. These involve the use of large muscles in the body such as trunk, neck, arms, and legs. Skills might include running, jumping, hopping, skipping, throwing, and catching. These photos show a child with head support at 3 months, sitting back round but able to hold head at 8 weeks, sitting back much straighter at 4 months, sitting with support of hand at 6 months. This is the tripod position, support with both hands. Sitting without support at 8 months, cribs position at 10 months of age, stand well at 12 months, child walking with one hand held at 12 and 13 months, walk with support, the child able to walk upstairs and downstairs on foot per step at 4 years. Fine motor skills. These skills involve the use of smaller muscles in the body, such as those of the eyes, hands, fingers, feet, and toes. Key fine motor developmental milestone. At 4 months, dexterous reach, reaching out for objects with both hands. At 6 months, dexterous reach, reaching out for object with one hand, transfers object. At 9 months, immature pincer grasp probes with 4 fingers. At 12 months, pincer grasp mature. At 15 months, imitate scribbles, tower of 2 blocks. At 18 months, scribbles, tower of 3 blocks. At 2 years, tower of 6 blocks, vertical and circular stroke. At 3 years, tower of 9 blocks, cubes circle. At 4 years, cubes cross, bridge with blocks. At 5 years, cubes triangle, gate with blocks. The child bring hands in the midline as he plays at 3 to 4 months of age. Dexterous grasp approach to handling ring at 4 months. A child mouthing an object at 6 months of age, use both hands. This is the child scribbles spontaneously at 15 months, at 3 years, circle, and so on. And this is the blocks at 15 months, tower of 2 blocks, 18 months, tower of 3 blocks, and so on. Variation of normal posture. Variations are common and may be noticed by parents or on routine developmental surveillance. Most resolve without any treatment, but if severe, progressive, painful, function limiting, or asymmetrical, they should be referred for a specialist. The normal toddler has a broad base gait. Many children evolve leg alignment with initially a degree of bowing of the tibia, causing the knee to be wide. Bow leg can be normal up to age of 3 years. If persistent, consider disease like rickets, osteogenesis imperfecta. Knock knee. The feet are wide apart when standing with the knees held together. The intermalleolar distance should be less than 8 cm. It is seen in many young children and usually resolves spontaneously. Considered normal age range from 2 up to 7 years. If persistent, consider juvenile idiopathy. Flat feet. Toddlers learning to walk usually have flat feet due to flatness of the medial longitudinal arch and the presence of a fat bed which disappears as the child gets older. An arch can usually be demonstrated on standing on tiptoe or by passively extending the big toe. Considered normal up to age of 2 years, marked flat feet are common in hypermobility syndrome. This is a photo of Entowing. There are 3 main causes of entowing: metatarsus varus, an adduction deformity of a highly mobile forefoot; medial tibial torsion at the lower leg, when the tibia is laterally rotated less than normal in relation to the femur; persistent anteversion of the femoral neck at the hip, when the femoral neck is twisted forward more than normal. Considered normal up to the age of years. This is a photo of entowing and outtowing. Toe walking, common in young children and may become persistent, usually from habit. The child can walk normally on request. Considered normal up to the age of 3 years. Habitual toe walking needs to be distinguished from mild cerebral palsy or tightness of Achilles tendons or inflammatory arthritis in the foot or ankle. In older boys, Duchenne muscular dystrophy should be excluded. Limping child. Deviation from a normal age-appropriate gait pattern can be caused by a wide variety of conditions. In most children, limping is caused by a mild self-limiting event such as contusion, strain, or sprain. In some cases, however, a limp can be a sign of a serious or even life-threatening condition. Delays in diagnosis and treatment can result in significant morbidity and mortality. Limp can be divided into acute painful limp and chronic or intermittent limp, where pain may or may not be the presenting feature. Causes may be congenital, as short femur, clubfoot, developmental dysplasia of the hip, fracture as slipped femoral epiphysis, infections, osteomyelitis, septic arthritis or transient synovitis, hematologic in hemophilia, malignancy as leukemia or osteosarcoma, intra-abdominal causes as appendicitis or neuroblastoma, inflammatory arthritis as GIA, rheumatic fever, reactive arthritis, systemic lupus, developmental as leg bursa disease. Transient synovitis, or what is called irritable hip. This is the most common cause of acute hip pain in children. It occurs in children aged from 2 to 12 years old. It often follows or is accompanied by viral infection. Presentation is with sudden onset of pain in the hip or a limp. The pain may be referred to the knee and there is no pain at rest, but there is decreased range of movement, particularly internal rotation. The child is febrile or has a mild fever and does not appear ill. It can be difficult to differentiate transient synovitis from early septic arthritis of the hip joint, and if there is any suspicion of septic arthritis, joint aspiration and cultures are mandatory. This is plain X-ray. This is the femoral head, which is fragmented and rod. Slipped capital femoral epiphysis results in displacement of the epiphysis of the femoral head posterior-inferiorly, requiring prompt treatment in order to prevent avascular necrosis. It is most common at 10 to 15 years of age during the adolescent growth spurt, particularly in obese boys, and is bilateral in 20%. There is an association with metabolic endocrine abnormalities as hypothyroidism or hypogonadism. Presentation is with a limp or hip pain, which may be referred to the knee. The onset may be acute following minor trauma or insidious. Examination shows restricted abduction and internal rotation of the hip. Diagnosis is confirmed on X-ray, and a frog lateral view should also be requested. This is a photo of slipped femoral epiphysis. Red flags: duration of symptom more than 7 days, pattern and severity of pain and limp. Severe localized joint pain should raise suspicion for septic arthritis. Change to urinary or bowel habit. Functional limitation, complete inability to walk, or weight bear may indicate significant pathology. Nocturnal pain and symptom. Systemic symptoms: fever, night sweat, chills, rigors, rash. Constitutional symptoms: unplanned weight loss, lethargy, easy fatigue, anorexia. Consider malignancy or hematological cause. Fever. How to diagnose? Examination: erythema marginatum as in rheumatic fever, may be hepatomegaly, lymphadenopathy, splenomegaly as in malignancy or some rheumatological disease, joint swelling, infection, inflammation, bleeding, reactive arthritis, malar rash as in systemic lupus. Investigation: anti-nuclear antibody test positive in systemic lupus erythematosus, anti-streptolizin or tetra high in rheumatic fever, leukocytosis and high CRP ESR in infection and inflammation of rheumatic disease, coagulation profile abnormal in hemophilia, synovial fluid culture for septic arthritis, imaging, X-ray, CT. And this is the causes of acute painful limp and chronic intermittent limp. From 1 to 3 years, the most common cause are infection, septic arthritis, osteomyelitis, transient transverse synovitis, and we must consider trauma and malignant disease. From 3 to 10 years, the most common are transient synovitis, then septic arthritis, trauma, Persis disease, and rheumatologic malignant disease. From 11 to 16 years, trauma, overuse, slipped capital femoral epiphysis, avascular necrosis, reactive arthritis, juvenile idiopathic arthritis, and osteochondritis, tumors, and malignancy. Causes of chronic and intermittent limp: developmental dysplasia of the hip, neuromuscular as cerebral palsy, juvenile idiopathic arthritis, Persis disease, neuromuscular disease as Duchenne muscular dystrophy, juvenile idiopathic arthritis, and from 11 to 16 years left capital femoral epiphysis, juvenile idiopathic arthritis, and the causes are the same but with differences in the distribution according to the age.